Occasionally on NANNcast, we'll have important news from NANN or our sponsors. We're so grateful for the support that allows NANNcast to keep producing engaging content and help drive improved neonatal outcomes. It's conference time, and registration for NANN's virtual 37th annual conference is open. There's no doubt we'd all love to be together in person this fall, but budget and travel restrictions, as well as safety concerns related to COVID variants, are keeping us safe at home. NANN's conference offers more than 40 hours of CNE available live September 13th through 15th, 2021, or on demand through February 1st, 2022. This means you can apply some credits to 2021 and some to next year. Don't miss out on the new virtual ways to connect with your nursing peers while receiving the latest education on hot topics like marijuana and breastfeeding, transplant, acute kidney injury, Down syndrome diagnosis, and so much more. Secure your spot today at nann.org/conference. Hi, and welcome to NANNcast. I'm Jill, your host. As NICU nurses, we all know everything we do in the NICU has long-term impact to our tiny patients. These babies who begin their lives in this environment may experience altered sensory experiences, as well as the disruption in the parent-child interaction. Such early experiences can affect an infant's attachment and increase the risk of developmental, behavioral, and emotional challenges. How can NICU nurses provide developmentally appropriate sensory exposures and better understand how factors such as the environment, medical conditions, and interventions of brain structure affect infants' long-term outcomes? This is where neonatal therapists come to action. Using an integrated neuroprotective, family-centered model, neonatal therapists provide highly specialized and individualized therapeutic interventions in the NICU. Parent involvement and experiences with their baby is vital in every stage of development, and we must encourage parents to work with therapists. It is my pleasure to welcome neonatal therapist Sue Ludwig to discuss ways NICU nurses can collaborate with neonatal therapists to provide neuroprotective care to impact and improve long-term outcomes. Sue Ludwig is a sought-after speaker, consultant, writer, and educator, a licensed occupational therapist and board-certified neonatal therapist. She is the president and founder of the National Association of Neonatal Therapists, where she uses her unique blend of clinical expertise, innovation, and leadership skills to support the advancement of this specialized field on a global level. Let's get right into it. Hi, Sue. Thank you so much for joining us today. So every NICU strives for an optimal neuroprotective healing environment for infants, but to do this, we really need to work on a multidisciplinary level. What is the role of occupational and physical therapy in the NICU?
Well, first of all, thanks for having me. It's great to be here. And the role of occupational and physical therapy in the NICU is really to optimize development both in the NICU, so kind of in every stage of development within the NICU, but also really looking at the long-term neurodevelopmental outcomes of the infant. So we're trying to look at the baby that we're seeing today and think about what has to occur developmentally to support that baby's development into the future. So we do that through assessments, both standardized, observational assessments, and through hands-on intervention. We look at neurobehavioral system, the motor system, musculoskeletal system. We look at pre-feeding and feeding, decreasing stress, sensory system, working with parents, et cetera, to achieve those goals.
So what does it mean to be a neonatal therapist?
That's a great question, because I think for a long time we just said, oh, I'm an OT and I work in the NICU, or I'm a PT and I work in the NICU. And what it means to be a neonatal therapist is really that you have decided to and are specializing in the NICU. And so you are engaging in NICU-specific education, continuing education, and mentoring and things like that, so that you are specifically trained and prepared to work in that environment. And you likely also have some, real dedicated hours to the NICU. So it basically means that we're specializing in that environment.
So what exactly is a certified neonatal therapist?
A certified neonatal therapist is something that has only been in existence, for maybe 5-ish years. So in about 2014, and the National Association of Neonatal Therapists had a vision about creating a certification for neonatal therapy, for a kind of a unique certification for all three disciplines, meaning that we would be that these therapists would be certified in a core set of knowledge that we all share. So while we each have our individual scopes of practice as therapists for OT, PT, and speech, we do share a lot of common ground that we have to know in order to be safe and effective in the NICU. And so we've formed a board that was independently run the entire time, and they eventually created a certification process, so a board certification process that is independent of NANT, in which therapists can take steps in order to become certified in neonatal therapy. And so there's some of the criteria for that are, a minimum of 3 years as a therapist, period. So no matter as a licensed therapist in any setting, and it has a number of hours that you've had to work in the NICU, number of hours for NICU-specific education and mentoring, and eventually passing the certification test, the exam. And so through that process, we now have, it's at least over 500 certified neonatal therapists, and maybe they're going to kill me, but maybe even quite more than that. And the really cool thing is it's also international. So we've had a lot of international participation because they can go to different testing centers all over the world.
So a lot of units tend to use rehab physical therapists, rehab occupational therapists that work, generalized, maybe just in a children's hospital and deal with older children, or if you happen to be in a NICU in an academic setting where there's adult nursing as well. So those nurses have a little bit more special training. Is that a different kind of model than what you would use in a traditional pediatric rehab?
Definitely. So what you're describing, we would call more of a rehabilitation model, where the therapist's primary goal is to go in and rehabilitate something that's already occurred. So a problem, an issue, a challenge neurologically or whatever the issue is. And we would be rehabilitating the infant. But in the NICU, our main goal is prevention and neuroprotection. And then also, when necessary, we may be rehabilitating, something that has occurred for the infant. But as far as how we deliver services, in a more rehab model, the therapist is coming in like they would in regular peds hospital or adult acute care, et cetera, and kind of seeing patients and leaving typically. And they're getting a referral, they're coming in, it's very problem based. So, and what we'd prefer is that therapists who are integrated in the NICU, they're receiving referrals based on standard criteria, and every baby in the NICU, most likely, who is at risk for developmental problems. So instead of just coming in and treating problems and leaving, we are there integrated into the whole team and being able to work from day one in a more preventative model. And then we're just fully integrated into the team.
Yeah, I know a lot of units that use Epic for computer charting. There's parts when you admit a baby, if they fall into a category, they automatically get a referral to occupational physical therapy, which is really helpful because we start to, discover what babies need help and discriminate amongst them to get those referrals and to have physical therapy and occupational therapy involved with them from the start. I think a lot of nurses are more in the, this is a rehab model where, my baby has a club foot or shoulder dystocia. We need to get rehab here, physical therapy here to see this baby. But a lot of times I think we're not putting the importance of preventative intervention and having these neonatal therapists work with our babies at birth, whether they're, premature or term.
Yeah, I agree. And I think that's how therapists started in the NICU way back when, is that we were in that model. That's how we first started to kind of be referred, into the NICU because of those types of issues. But the longer we were there seeing those types of problems, the more we realized that, hey, we could have also been working on this. We could have actually prevented some of the iatrogenic problems that we're seeing from poor positioning or other things, or been involved earlier and helped prevent some of the feeding aversion. So over time in history, we've sort of moved back and back and back earlier and earlier in the baby's stay and in their lifespan into that more preventative model instead of just coming and seeing a problem and really seeing the baby more holistically and within the infant and parent dyad as well.
Yeah, I know in my unit and a lot of other NICUs, we really incorporate OT-PT in our developmental care committees. We always ask them for their input and what positioning aid would work, or can you bring in a positioning aid that you think would work for this population or these babies that we're seeing issues in. And it's imperative to have such a great collaboration with the neonatal therapist in order to provide the best outcomes for these kids early on. Because, we work so closely together. And I think that really helps build our relationship with you as well as your relationship with the parents, and to look at it as a more team approach than just that's what you do and this is what nursing does.
Yeah, I couldn't agree more. That when we are all working collaboratively, then the parents better understand what's going on many facets with their infants, and we can all contribute in a way that's meaningful for the parents and the infants.
So in your ideal world, how do you think it would look when a NICU nurse is working really well with a therapist, and how would you create that kind of relationship on a unit that's just introducing neonatal therapists or even a unit that's working closely with more of a rehabilitation model of therapists?
So let me answer your first question first, and then I'll go back and think about what that would look like as you're integrating therapy into your team. But the ideal picture to me is that, therapists do have some sort of standard referrals that make them an integrated part of the NICU. And then that our relationship with the nurses is pretty seamless, meaning, and I'll just give a specific example if that's okay, because I think it illustrates it better. But I remember years, I probably had been in the NICU for 15 years or something by now, but I remember a nurse coming to me real early in the morning, and she said, "Hey, would you mind seeing, baby so-and-so with me this morning?" And I said, "Sure, what's up?" And she said this baby was brand new, 24-weeker, very fragile, and that the baby didn't tolerate care very well at all without becoming unstable. And so she said, "I just know that the baby will tolerate the care better if there are two of us. And if you're doing what you do well and I'm doing what I do well, I think she'll do better." And so we went to the bedside together. I'm using what I know through my lens to help the baby feel secure, to keep their extremities tucked in, to do all the things I know that calm the nervous system, while that nurse was doing all of the things that she had to do with both hands because this was a fragile, tiny baby and she needed both hands to do what she was doing. And we worked seamlessly in tandem to provide that baby with a safe experience, a comforting experience, and not with very few stress signs, whether they're motoric or autonomic stress signs. And the baby, because we were both doing what we were, came there to do, but in such collaboration, the baby was more stable, went, kind of back into more of a sleep state more quickly. It was sort of a win-win-win situation. Meanwhile, I'm also looking at all types of things as an assessment. So I'm looking at, is this baby symmetrical? Does the baby's, are their movement patterns symmetrical? Are they age appropriate for a 24-weeker? All the different neurobehavioral pieces and things like that. So I'm able to do that while we're doing what we're doing together. I'm not coming in separately necessarily. I wouldn't come and separately assess a 24-weeker, and where, and possibly stress that infant out. To do that, I'm going to work when we're already in there together and things like that. So in that, and that's one example, but the main point is that we understand what each other brings to the table. She understands also a lot about neurodevelopment and protection, and that's why she asked for me to come there. Now, to your second question, if you rewind the clock by 15 years, that is not what a nurse would have asked me with a 24-weeker and a brand new 24-weeker at that, because it would have been perceived then that I would be, having a therapist come and see a baby that was that fragile would be stressful, unnecessary. What are you going to be doing in there? And quite honestly, I wouldn't have known enough right away to be therapeutic in and of myself. I didn't have the skill set yet. And so with time and experience and mentoring and all of that, those things can happen very well. But it takes the therapist having like the humility and the teach me everything you know as nurses piece, so that you can interact well in that situation. And then it also, of course, takes the nurse being open to teaching the therapist and working and collaborating in the beginning, so that we both understand what the skill set is. So for the therapists in that more rehab model who are coming in and then say, well, what else can I do in here? What else can I do besides, work on the club foot or work on positioning? I think that my advice would always be for the therapist to start with what their current skill set is with very stable infants and keep becoming more and more educated in the unique needs of premature babies at every age. And then really ask for mentoring from nurses, from doctors, from the respiratory therapists, et cetera, as you move back in gestational age and fragility with those patients. So I'd start where you're comfortable and then move back with a lot of help, and a lot of ongoing mentoring and education.
Well, I think we need about 20 to 40 of you to help us with our care for our extremely small babies that we have, like the 24-weekers, because it's so hard as a nurse to maintain that neuroprotective environment while you're trying to do care, that it would be amazing to have one of you with us at every time we have to do care. I know that I struggled. I did a whole IVH prevention bundle, risk prevention bundle, and I used our therapist so much to say, okay, can you help us as nurses to, correctly handle these babies and maintain a neuroprotective environment and decrease stimulation? And they were so helpful with us. And they designed a lot of pictures and different positioning things that we could reference while we're doing our care and to maintain that great healing environment for them. Always remember your therapists are there to help, even with doing even QI initiatives. Like we need to be more collaborative when we're doing things like that. So I'm sure that nurse greatly appreciated all of your help. You are invaluable to bring on the correct use of products and positioning aids that we have on the unit. I think that's also a really important role.
I agree. And I think, it's so great when we can collaborate, because as a therapist, I may know all the neuromotor and musculoskeletal pieces of the positioning, but I really might need your input in how do we best do that without putting more pressure on the septum if the baby is on CPAP or something like that. So, and how do you want these lines positioned, and how, so all of the things when we collaborate, I think is really a win-win for the baby. And then we really provide the highest level of care when we're having those conversations.
And I think, the medical team is also on board with this. The nurses can only push so much, but I think the medical team needs to be on board. I think they need to promote this as well, and to see the importance of therapy on these babies, especially. Sometimes the docs will say, no, we can't do that now. They're not stable, but they're stable enough to do some things. Like we can always try to, even just doing calming measures, or ways to provide boundaries. I think that it's important to use therapists even in rounding and give out your suggestions for things for the babies that may not be stable enough to really have intense therapy.
Yes, I agree completely.
Oftentimes when we tell parents that the physical therapist or the occupational therapist is going to come work with their baby, the parents are in shock, kind of like, why do they need a therapist? You know, they're not walking, because they're thinking more the rehab model that we talked about earlier. How do therapists work with parents, and how do they get them involved in the neonatal therapies that you are giving to their child?
Well, the first thing, just to your point, the first thing I like to tell parents is that we're not here because something is wrong, typically. Not that there couldn't be a specific thing like we were talking about, but that in general, we're here as sort of the earliest of early intervention to help best support their baby's development while they're in the NICU. So we typically explain that, their babies were developing in utero, and certain things were happening. Their muscles were developing, their muscle tone was developing, their brains are developing, their senses. That was all happening in utero. And then out here in the NICU, all of those systems have to adapt developmentally. And so part of our role is helping their babies' brain, sensory systems, musculoskeletal systems adapt to this different environment. And that doesn't mean anything's wrong. It means that they were just here early, or with how things develop over time, and trying to really get in there early and teach the parents some really constructive things they can be doing and while they're, instead of just sitting at the bedside.
Oh, I agree. I love to see the parents when they have a preemie that's feeding and growing and making the way out, how they're working on exercises, and they get really involved with their child, and it makes they feel like, hey, I'm making a change, and I'm doing something for my baby now. And I it's so nice to see that bond and relationship grow.
One of our primary goals is really connecting the babies and the parents, because we all know how powerful that is from a neuroprotective standpoint, from breast milk production, from from psychologically, et cetera, for the infant and mom. And so we do some of that just in very similar ways that you guys would, with skin to skin holding and things like that, and trying to facilitate those experiences, but also trying to help, from an OT perspective, there can be a loss of role for the parents in what they expected to happen and in what is happening, and how do they feel like a parent when we're all doing what looks like parenting work to them. And so, getting them involved in as much as soon as possible, as soon as is recommended based on the situation, with diaper changes and temperatures, and just caring for their infant, and that to help fulfill that role and help them attach to their baby and help them, learn some real parenting skills is one way that we would interact with them. And so we would grade that based on the baby's gestational age and acuity for what's appropriate, of course, and help them, try to not be afraid to touch their baby or hold, if it's a hand hug inside the isolate, or whether it's coming out and holding them skin to skin. And then even, teaching them things they can do way early to help facilitate oral feeding later. Like, how do we keep the sensations around the mouth and the face positive, and how can they play a part in that? So all kinds of things that we can teach them about where their babies are in their development that they usually find pretty fascinating about, this is what's happening with vision right now. This is what's happening with your baby's hearing. This is what, how we want to help develop their, sense of touch and things like that.
So you mentioned when you work with parents, you talk about creating positive oral environments, and so that goes hand in hand with initiating feeds. Can you tell us a little bit of how neonatal therapists are in feeding initiation and the role they play?
Yeah, so I think we're thinking of that from day one, as far as from a sensory standpoint. How do we help the infant have an approach to feeding and tolerate things, around the face and mouth and swallowing and all these things from the beginning. But with parents being involved with that. But then when oral feeding becomes appropriate, Obviously, we'd be supportive of, if the mom's breastfeeding, then we're going to be supportive of that. If the mom has chosen to bottle feed, and then we'd be supportive of that. And I think, to me, one of the biggest things I had to learn as a therapist over the years was that it's not about me. That it's not like as a therapist, I need to come in and be the hero of the story. I don't need to be the first person to orally feed that infant in order to say, this can now begin. And so there obviously has to be things in place in the unit where there's a process and things for assessing oral feeding. But really trying to have that first oral feeding be with the parents and them being the feeders. And, obviously if it's breastfeeding, that's required. But even with bottle feeding, sometimes we don't think of that. We don't think how special it might be for the parents to give the first oral feeding. And I just have talked to so many parents over the years where that was devastating to hear on the phone, maybe, that their baby took their first bottle or something like that. And we're excited, but, they're potentially devastated. And so prioritizing that relationship and giving them the confidence and sitting there with them, of course, and teaching them so that it is a safe experience for the infant is a priority, of course. But really having them be the ones that become the expert feeder of their babies goes a long way to improve the culture we used to have about feeding and to make sure that the lens is really on them because, we're not taking their baby home. So the most important thing is that they get comfortable with feeding, that they understand what's going on, and really, making them, and it takes the whole unit kind of to prioritize that. Because if you, as a therapist or as a nurse, you want to prioritize that the parent does the first oral feeding, but the medical team is like, why are we waiting till 3 p.m. today? Why aren't we doing this right now? Or why are we waiting till tomorrow? So it does have to be an initiative that the whole team supports. And obviously we're not going to wait 2 weeks, most likely to start oral feeding, but in general circumstances, parents are, in the unit a lot, that should be a priority. So, I just think as therapists we have to consider what is the real goal of that feeding experience beyond all we know. We can use all we know while supporting the parent and not having to do it always ourselves.
That's great insight because I feel like we in the NICU kind of work on a very rigid schedule. They eat every 3 hours at this time. And a lot of times we forget, like you said, that we're excited because the baby took a bottle, but like we didn't offer that to a family member or a parent to do because like that was our schedule and the mom didn't happen to be there and the baby was showing cues, so we're going to do it. And we do. It's a whole change in mindset, but it's very insightful to hear this as a nurse and the impact that we have on the parents, especially with these milestones that these babies achieve in the NICU. And we really do need to make that a priority and to make them a priority and not always schedule everything around when it's best for us, but maybe when it's best for the parent.
Yeah, it's tough. I mean, it does take a lot of communication and doing all of it for the right reasons and having a process. So I feel like it becomes really stressful if someone goes in the next day and says, this is what we're going to do. And, without kind of having the process in place and things like that. So I think, just taking that into consideration and moving toward it, as a team is, more important than, say, doing it tomorrow.
Yeah. And also, I'm a night shift nurse. So speaking as a night shift nurse, we don't have the availability of therapists overnight. And they're not oftentimes there. And, sometimes parents can't visit during the day and they're visiting on the evenings when the therapists, aren't there. So that's also a struggle, off-shift nurses face with, how do we continue these therapies that are done during the day and also educate the parents on what's been done and how they can model those behaviors too while, they're visiting at night. And that's one struggle that I think a lot of nurses face when we're looking at a multidisciplinary approach, because they're not there at night. They're not there. And unfortunately, sometimes they're not there when the parents are there. So how do you coordinate that is a difficulty.
It is. And I think, again, it takes a lot of communication, and also, and I think as a therapist, I would want to say to night shift nurses or, some therapists like in the unit where I used to work, they actually start super early in the morning while night shift is still there. So it's not, at night, like 11 p.m., but it is in the morning. And that has helped some of that communication and adoption of things, because they're just seeing the therapist, and talking to them and things. But I think, as therapists, going to the nurse and saying, what is helpful for you? So before, I want to share what the plan is, but I want it to feel collaborative, and I want it to feel like it makes sense. And what is different about night shift, and what should we be thinking about? So yeah, but it is tough. It's probably why night shift nurses love night shift, right? There's no one around.
Yes. But I would love to have you around to do the care on my little babies and help out with that neuroprotective environment that you talked about earlier. That would be awesome. But it's just, I find myself constantly reading notes and updates that are in the chart, so I can kind of, what did you do today? So I could continue that, during my shift. I know a lot of our therapists take pictures and put them at the bedside so we can see what positioning aids work best for our babies. So we're very thankful for that form of communication as well. And I know it's a challenge no matter, whatever shift you work at, there's different challenges. And that's something that comes with, trying to be collaborative at night and maintaining that relationship. So we talk about everything that a neonatal therapist can do to help the babies and our families, but does every NICU need neonatal therapists?
Yeah, so I'm going to have a biased opinion first, but I'm going to say not just my own opinion, but I'm going to say yes, meaning that it's been collaboratively decided, and we were, as an organization of therapists, we were, in conversations with the AAP about their NICU verification process and things like that, and what should be present at a level 3 NICU, a level 4 NICU from a staffing standpoint for all disciplines. And the paper that was written in response to that by Craig and Smith, which I believe you're going to make available with the recording, addresses this, but basically in a nutshell, that level 3 and 4 NICUs, yes, should have OT, PT, and speech available in an integrated model where they are part of the NICU team, and that level 2 NICUs should have the availability of trained neonatal therapists, whether that's an integrated model, or if there's not enough of a demand from a bed number of patients and census standpoint, that they would be able to call in more of a consultative service for a neonatal therapist. So depending, if sometimes they're very small level 2s that might not be able to have an FTE or something, but that they would have someone that they could reach out to who is trained in neonatal therapy, so that patients would have access to neonatal therapy. So the short answer is yes. And I think that article does a very nice job of explaining why. It also has some staffing formulas and things in there as far as number of FTEs. So I think that's a very helpful reference, whether you're a therapist or a nurse or a neonatologist or anyone trying to figure out what that model should look like in your NICU.
Are therapists involved in discharge planning and providing recommendations for families or for the medical team on how to move forward beyond those NICU doors?
Yes, for sure. So we definitely are involved in discharge education in all of the areas that we have been seeing the patients throughout their NICU stay. So we're hopefully start that way before discharge, but we're definitely going to make sure the parents, have what they need to continue what we were doing in the NICU at home. And then we also help guide the services that babies may need or may be connected to outside of the NICU. So not every NICU has a NICU follow-up clinic, but if they do, we're going to make sure that the appropriate babies are referred for that from our perspective anyway. And then also for early intervention services that are typically guided by each state and funded by each state. And so we want to make sure that whether it's our role to do that or at least just recommend that, or it depends on how your unit operates, but we're going to make sure that they're connected so that the babies that are at higher risk or really at any risk for developmental delay will be connected to their community resources so they can continue therapy. And we want to do that as soon as possible because there's often a delay between a NICU discharge and when babies first get early intervention at home.
So oftentimes these babies already have appointments set up before they get discharged to make sure that we don't have any gap between care. Is that pretty much the standard of practice?
Yeah, they would have some sort of referral to early intervention, and then depending how that state runs their early intervention program, they would be, entered into that system. But no matter what, there is in many states there is still a delay, sometimes significant, just by how it works or supply and demand or all the different factors. There can be a delay. So just as soon as that can happen, the better. So we don't miss a lot of little iterations on the way to milestones.
So I hear that you have some exciting news, and on NANNcast, we always like to highlight people that have amazing accomplishments. So let us know your news.
Thank you. So I wrote a book. I've been working on it for a long time, and I'm finished writing it. It's in the publication process, and will come out in March of 2022. And so the reason I'm telling you guys this is because it is kind of an intersection between the NICU and life. So the title of it is called Tiny Humans, Big Lessons, How the NICU Taught Me to Live with Energy, Intention, and Purpose. And so it's a really different book because I'm taking the lens of the NICU and my world as a neonatal therapist and pulling the cover back a little bit to people who are not ever been in a NICU about what those babies teach us every day by how they survive and how they thrive and all of how their systems are developing and all the things that we know are pretty miraculous to watch unfold in a NICU that most people would never have any exposure to. But then I'm also kind of taking that lens of being a trained observer of these tiny babies and sharing what happened when I took that same lens and put it on my actual own life. And what I mean by that is probably in my mid 30s or so, I was pretty exhausted from working and motherhood and the few jobs that I was trying to do all at the same time and the projects and the research and the stuff. And I was very overwhelmed and exhausted, but I was also kind of underwhelmed with how I felt about my life. And so I kind of went on a little bit of a journey, blah, blah, blah. And what I really found was so many of the answers to me kind of getting off the hamster wheel I had put myself on in life and building a life that was more intentional. So many of those lessons I actually found back in the NICU. And from the babies and from what we know about how to protect someone's energy and how to scatter someone's energy and what early stress cues really look like before we're overwhelmed with autonomic stress cues. And all of these comparisons that were really quite intriguing to apply to my life, and I think will be for all of us, I hope. So that's kind of the what I hope. And so there are some, tools and insights and practices that are tangible in the book. But it definitely has a NICU focus, but it is not just for NICU people.
That sounds awesome. I think that's very relatable. We've all been there on that hamster wheel. And I feel that everything that you're talking about and what you're going to write about and explain seems very inspiring, not to just nurses, but everybody out there struggling with kind of finding their why and their purpose in life and take a step back. But thank you so much for sharing all of your neonatal therapy knowledge with us and really expanding our ideas of what you're doing and how we can collaborate better, to provide a neuroprotective healing environment in our NICU, because that's what we're here for, for our babies, and to have these great, amazing outcomes so they can be the best they can be. So thank you so much for joining us today.
Thank you very much for having me. I really appreciate it.
Make sure you never miss an episode of NANNcast by subscribing now. This podcast is made possible by listeners like you. Thanks for your support and letting us into your ears. Have a great day.